If you're over 60 and you stopped taking your statin in the last few months, I need you to stop what you're doing right now and listen. Maybe the muscle pain got bad. Maybe a friend told you to throw the bottle out. Maybe a headline scared you and you decided enough was enough. What I'm about to share with you is data published in the Lancet in February 2026. 150,000 patients tracked over 5 years. It has changed how I talk to every single one of my own patients about quitting cholesterol medication. Stopping a statin is not a neutral act. The new data shows what happens in the next 90 days that nobody warned you about. I'm Dr. Richard James, and after more than 3 decades in cardiovascular medicine, the question I get asked most by patients over 60 is this one. Doctor, can I just stop? In the next 18 minutes, I'm going to walk you through exactly what happens inside your arteries the day you take your last pill, the 90-day window where most strokes occur, and the safe way to come off, if coming off is even the right call for you. The last decade has been dominated by anti-statin headlines, books, podcasts, long YouTube comment sections. Millions of seniors have quietly quit on their own without ever telling their cardiologist. That decision feels small. The Lancet data says it isn't. The average secondary prevention patient who stops a statin without a plan is roughly 33% more likely to have a stroke or a heart attack inside the first year. The curve bends fastest in the first 90 days. A study published in the Lancet in February 2026 followed 150,000 patients across 21 cohorts for 5 years. It found something that quietly contradicts what the YouTube comment sections have been telling you for the last decade. Here's the part that disturbs me most. Almost every patient who stopped told me they did it because their doctor was fine with it. How can both be true? Stay with me, because before you decide what to do with that information, you need to understand the one biological process that the headlines never explain. You are not alone. According to multiple registries, including data tracked through Mayo Clinic and the American Heart Association, somewhere between 3 and 5 out of every 10 seniors who start a statin stop within the first 12 months. Let me say that again, because it's bigger than most people realize. Almost half of all patients who are prescribed a statin stop taking it inside the first year. Most never tell their cardiologist. They just stop refilling. They throw the bottle in the kitchen drawer. They tell themselves they'll get back on it eventually. Life goes on. For a while. That quiet, undocumented quit wave is exactly what the Lancet team finally measured. The drivers are easy to list. Number 1, muscle pain. By far the most common stated reason. Number 2, brain fog or memory concerns, often blamed on the medication, even when the timing doesn't fit. Number 3, a fear of long-term side effects, especially diabetes risk and liver concerns. Number 4, a family member, a friend, or a podcast host who said your doctor is just selling you pills. Number 5, a quiet, unspoken belief that aging is the problem and the medication is the punishment. I understand all 5 of those drivers. I've heard them in my office every single week for 3 decades. What I want you to understand is that the act of stopping is rarely a single decision. It's usually a slow drift, a skipped dose here, a delayed refill there, a vacation where the bottle gets left at home and never quite makes it back into the routine. Then one morning, you realize you haven't taken your statin in 6 weeks. This is the part most doctors miss entirely. We ask, are you taking your medication? We get an answer that's somewhere between optimistic and aspirational. Many patients are not lying. They genuinely intend to take it. They simply haven't been, for longer than they realize. Now here's the part that nobody in cardiology talks about openly. The medical system does not have a clean way to measure this. Pharmacy refill data captures part of it. Patient surveys capture part of it. The actual silent quit wave, the people who stopped without ever saying a word, was largely invisible to the data until very recently. That invisibility is what the Lancet finally pierced. Their team didn't just count how many people had been prescribed statins. They counted patients who had filled prescriptions, then stopped filling them, then linked that pattern to actual hospital outcomes: strokes, heart attacks, cardiovascular deaths. Here's where it gets really concerning. The Lancet didn't just count how many people quit, they counted what happened next. That is the part I have to walk you through carefully. Before I tell you what they found, I need you to understand what is physically happening inside your body once that pill is gone. Take your last statin pill. Within roughly 24 hours, the drug is largely gone from your bloodstream. Your liver, which had been quietly throttled in its cholesterol production, slowly returns to its old habits. Within 2 weeks, your LDL cholesterol, the so-called bad cholesterol, rises measurably. In some patients, it rises sharply. In others, it slowly creeps back up. Within 4 to 6 weeks, in many cases, it has returned to where it was before you ever started the medication, sometimes higher. That part you may have expected. Higher number, higher risk. Pretty intuitive. What you probably did not know is that lowering LDL is only one of the things a statin does inside your body. The other effects are called the pleiotropic effects. That word means many actions. Statins have a lot of them. They reduce inflammation in the wall of your arteries. They stabilize the surface of any plaque you already have. They improve the function of the inner lining of your blood vessels, called the endothelium. They slightly reduce the tendency of your blood to form clots. These effects are not minor. They are part of the reason statins reduce stroke risk so dramatically in patients who already have heart disease. Stop the pill, and within about 2 weeks, those anti-inflammatory effects begin to fade. Stop it for a month, and a plaque that was stable, calm, and well-behaved becomes vulnerable again. The protective lid on top of it, the part that keeps it from rupturing into your bloodstream, thins. The inflammation underneath quietly returns. Now this next one is the one I lose sleep over. When a previously stabilized plaque becomes vulnerable, it does not announce itself. There is no warning sign, no symptom, no chest pain to tell you something has changed. You feel exactly the same, maybe better because the muscle pain is gone. Then one ordinary morning, weeks or months after that last pill, that plaque tears. A clot forms on top of it within seconds. If that clot lodges in a coronary artery, you have a heart attack. If it travels to the brain, you have a stroke. This is why a stroke can happen in someone who felt totally fine 3 weeks after they quit. That is the part the headlines never told you. They told you about side effects. They never told you about the silent return of the very thing the medication was holding back. Listen to this. The patient feels better in the first weeks after stopping. The muscle aches fade. The sense of vague chemical fog lifts. They take this as proof that quitting was the right decision. The body sends back nothing but a green light. The clock, however, has started. That is what stopping does. That is what the Lancet measured. Now I want to answer the second question. The one you asked when you watched your doctor not push back. Why didn't your doctor warn you? I want you to think about the last time you actually talked to your doctor about your statin. Was it a conversation? Or was it 90 seconds at the end of an appointment when the nurse was already standing in the doorway with the next patient's chart? This is the part that frustrates me the most as a doctor. The medicine works. The decision to stay on it or come off it is enormous. The conversation about how to come off safely almost never happens in primary care today. There are 3 reasons for that. First, time. The average primary care visit in the United States is around 18 minutes. In that window, your doctor is reviewing labs, checking on 3 to 5 chronic conditions, hearing about your hip, your sleep, your worry about your spouse, and trying to address whatever you came in for. The deprescribing conversation, what to do if you really cannot tolerate the medication, rarely fits. Second, deprescribing protocols for statins are not standardized in primary care. There is no single rule book your doctor can reach for. Cardiologists who deal with this question every week have a process. Most primary care physicians have intuition. Intuition is not a protocol. Third, and this is uncomfortable, many patients quit without telling their doctor at all. We don't say no because we were never asked. The next visit, you mention it casually. We update the chart. We move on. We do not stop you and say, we need to plan this carefully. We should. We don't always. You did not fail. The system failed to give you the conversation. There is a difference, and I want you to feel that difference clearly. This is not about defending or attacking your doctor. Most cardiologists I know would agree with every word I just said. They are doing the best they can inside a system that gives them 18 minutes to handle a question that deserves 60. If you are sitting there thinking, my doctor really did seem fine with it, you are probably right. Your doctor probably was fine with it because the deeper conversation never happened. I'm going to give you that conversation now, the one you deserved to have, the one the new Lancet data should make impossible to skip ever again. Stay with me, because this next part could save your life or someone you love. The 90-day window the Lancet identified is not the same for every patient. There is a profile of person who is in the most danger. You may already be on that map. Here is who is at the highest risk in the first 90 days after stopping. Number 1. Anyone with a prior cardiovascular event. If you have ever had a heart attack, a stroke, a stent placed, or a coronary bypass, even years ago, you are in what we call secondary prevention. Your statin is not lowering a number. It is holding back a process that has already shown it wants to come back. The Lancet hazard signal in this group is the largest. Number 2. Patients within 12 months of a recent cardiovascular event. The first year after a heart attack or stroke is the most dangerous window of all. Stopping a statin in that window is not a minor decision. It is, statistically, a major one. Number 3. Women over 65. Listen carefully here. The historical research literature has undercounted women in cardiovascular trials. The newer data is finally catching up. The discontinuation signal in women over 65 is not smaller than in men. In some cohorts, it is larger. Number 4. Patients with elevated lipoprotein A. This is a genetically determined cholesterol particle that most doctors did not check 20 years ago. Many seniors have an elevated LPA and don't know it. If yours is elevated, your statin is doing more lifting than your numbers suggest. Number 5. Patients with diabetes. The combination of diabetes and arterial disease produces a level of risk that statins blunt powerfully. Stopping a statin in a diabetic patient with cardiovascular disease is one of the riskiest behaviors I see in my own clinic. If you recognized yourself in any of those 5 categories, I need you to pay very close attention to the next 4 minutes. This is exactly where most people make a critical mistake. They look at the average risk and assume it applies to them. The new Lancet data shows it does not. Your subgroup matters more than the headline. Before I give you the protocol, there's something you need to understand first. It's the part that changes everything about how this conversation should go with your own cardiologist. I want to address the elephant in the room directly. You did not stop your statin because you wanted a stroke. You stopped because something hurt. Maybe your legs ached every time you climbed stairs. Maybe your shoulders felt heavy. Maybe you were waking up sore for reasons you couldn't explain. The pain was real. The frustration was real. I am not telling you the side effects you felt were imaginary. I am telling you that the choice you were given, endure the pain or quit the pill, was a false choice. Here is what most patients are never told. There are at least 5 clinical levers between your current dose of your current statin and 0 medication. Number 1. Switching to a different statin molecule. Some statins are far less likely to cause muscle symptoms than others. Number 2. Lowering the dose. A patient on 40 milligrams may do beautifully on 10 milligrams. Number 3. Alternate day dosing. Some patients tolerate every other day dosing comfortably and still get most of the benefit. Number 4. Ruling out and correcting vitamin D deficiency, which can mimic and worsen statin muscle symptoms. Number 5. Distinguishing between true statin-associated muscle symptoms and the nocebo effect, an effect documented in the Samson trial published in 2020, where patients reported muscle pain on identical placebo pills. Picture a representative profile, the kind this study describes. Let's call her Teresa, though she could be anyone with this profile. A retired school teacher in her late 60s, living alone, who came off her atorvastatin after 4 weeks of leg pain. The pain went away. So did her cholesterol control. By the time her cardiologist saw her again, her LDL had risen sharply. Almost no senior is offered those 5 levers before they decide to quit. Here is what I want you to take away. The Lancet 90-day stroke signal is not random. It is the predictable downstream consequence of 3 things happening inside your body at the same time. Your LDL rebounds. Your plaque destabilizes. Your blood vessel lining and clotting balance return to their old, dangerous state. Combine that with a system that gives most seniors no real conversation about how to come off safely, and you have, very quietly, created the exact conditions the new data is now measuring. This is not a statin problem. This is a quitting without a plan problem. The pill is not the villain. The empty conversation around the pill is. Once you see it that way, the path forward becomes simple. Not easy, simple. The next 2 minutes are the most important 2 minutes in this entire video. They are the 2 minutes you can act on. By the end of this section, you will know exactly what to do tonight, this week, and at your next appointment. Tonight, do not stop or restart your statin on your own based on this video. That is not what I am asking. Open the Notes app on your phone or grab a piece of paper and write down 3 things. The exact name and dose of your statin, the exact symptom you blamed on it, the date you stopped or the date you are considering stopping. This week, call your cardiologist's office. Not just primary care if you have both. Ask for a 20-minute telehealth slot specifically about, in this exact phrase, statin tolerability. Not a refill, not a checkup. At that visit, ask 3 questions. What is my secondary prevention status? What is the safest deprescribing protocol if we decide to come off? Have we tried switching the molecule, lowering the dose, or alternate day dosing first? If you have already stopped, bring up the February 2026 Lancet finding directly. Use the phrase, "I'd like to talk about restart and the 90-day window." Send this video to the one person you love most who has a statin bottle in their kitchen drawer. You might be the reason they don't have a stroke this summer. I'm Dr. Richard James. Take care of your heart tonight, and take care of the conversation we just had. Next week, I'm covering the new cholesterol target the guidelines just changed to, and what your old normal number is quietly doing to your heart right now. I'll see you in the next one.